Hello, everyone. Welcome to the Health for the World International Grand Rounds. Please feel free to introduce yourself and tell us where you're from. My name is Bhishak Kamat. I'm going to be the moderator for the session. I'm an associate professor of clinical radiology at Temple University Hospital. And the topic for today's Grand Rounds is endometriosis. It's a wonderful topic, I think, a really much needed topic of information in the body section. And it's my pleasure to introduce our speaker, Dr. Elizabeth Vandeventer. I hope I'm pronouncing that right.
Yes.
Dr. Vandeventer is an assistant professor of diagnostic imaging and a clinical educator at the Warren Alpert Medical School of Brown. Dr. Vandeventer got her MD degree from Drexel University, which is not far from where I am. Subsequently, she trained in diagnostic radiology and body MR at Beth Israel Deaconess Medical Center, a teaching hospital of the Harvard Medical School. This lecture qualifies for an AMA PRA Category 1 CME credit for US-based physicians. Dr. Vanderventer's talk will have a link and a barcode will be displayed on the screen for the same. Please feel free to claim the credit after the talk. We'll have a Q&A session after the talk, so please feel free to add any questions you have in the QA box. Thank you. Dr. Vandeventer?
All right, so I'm going to speak about endometriosis, and this is the link for anyone that needs CME credit and the QR code. I'll leave this up for just a few seconds before we move on. I also have it again at the end of my presentation if anybody misses it. All right, I have no relevant financial relationships to disclose. So what we're going to be talking about today is we're first going to touch on what is endometriosis, go a little bit over the clinical presentation, and then spend the bulk talking about findings on ultrasound and MRI. We'll touch basically on treatment and then discuss a little bit of interesting presentations, bringing it back to radiology. So what is endometriosis? Technically, the definition is when endometrial glands exist outside of the endometrial cavity and outside of the uterus. There are three main theories for how this happens. One is retrograde menstruation, where it's believed that during menstruation, instead of the cells sloughing off and progressing out through the vagina, they progress backwards through the fallopian tubes and land on the ovary or in the peritoneal cavity. Another theory is metaplasia, which is exemplified over here, where it's thought that there are just pluripotent cells that can convert into endometrial cells and then can begin menstruating. And then the third prevalent theory is induction, which is a combination of the two. So it's thought that there's either some form of retrograde menstruation or some form of lymphatic travel or venous travel, where it brings the cells or even sort of the hormones that are produced during menstruation to different parts of the body. And that induces these pluripotent cells to convert and then begin menstruating. Because what we have are these endometrial implants that are responding to the hormonal cycle, what tends to develop is fibrosis and smooth muscle proliferation. So this creates things such as adhesions and plaques in the body, and that can create the symptoms that go along with endometriosis. This is seen in about 3 to 15% of reproductive age women. It's a difficult diagnosis to make because some people are completely asymptomatic and some people have severe symptoms. So it's hard to know an exact prevalence. The mean age of diagnosis tends to be during the fertile period between about 25 to 29. The typical symptoms that we see are dysmenorrhea, dyspareunia, infertility, and chronic pelvic pain. Again, this occurs on a spectrum, which we'll talk about a little bit later. The three forms of pelvic endometriosis include superficial, ovarian, which is also known as an endometrioma, and deep infiltrating endometriosis. Endometriomas and DIE are what we can see by imaging. Superficial is too small for us to be able to see on imaging, and that's where, as we see down here, laparoscopy comes into play. The diagnosis for endometriosis is made in part by physical exam. There are multiple techniques that OBGYNs or internal medicine docs can do to evaluate for sort of specific tenderness and look for immobility of certain organs. Ultrasound and MRI are the mainstays of imaging that we perform to evaluate for endometriosis. And then laparoscopy is both diagnostic and can be for treatment, and that's considered the gold standard of diagnosis. So now we're going to dive into some imaging findings. So the first thing we're going to talk about is the endometrioma. We'll go over its presentation on both ultrasound and on MRI. So this is the most frequent site of endometriosis. It's in the ovary. What you typically look for are these unilocular or septated cysts, as we can see in all of these images. They have this classic presentation of either a ground glass appearance or what we call homogeneous low-level internal echoes. So we can see here, this is a simple endometrioma. It's within the ovary, and you can see that it has all these sort of gray speckles throughout. We have another example here. This one has a septation within it. And another feature that you can see, especially with chronic endometriomas, is they develop these thickened walls, and they can develop these calcifications. Similarly here, we have another endometrioma with a small septation, and a calcification as well. Another feature that we look for is what's called kissing ovaries. So here we can see that this is the right ovary and this is the left ovary. Both ovaries have an endometrioma, and we can see this is part of the uterus. They both moved, they've migrated posterior to the uterus and are now touching. And that goes along with the theory of adhesions and fibrosis. The important thing about endometrioma, as we said, is the most frequent site of endometriosis that we see. It also tends to be a marker for severity and can indicate that there's additional disease that we're not seeing. Some atypical features of endometrioma, we can see fluid levels, as is displayed here. This can occur depending on the menstrual cycle with varying levels of blood products. So typically in patients that have chronic endometriomas that are rebleeding, you can end up with this fluid level. Another atypical presentation is a solid nodule, which typically occurs along the wall of the endometrioma here. The nice feature about this is that we can see that it's avascular. They've put the color flow Doppler box over it, and there's no flow within. This is just within the wall. A third atypical presentation that we can see is decidualized endometriosis, and we'll touch on that with a little more detail in a little bit. So when we're talking about MRI endometriomas, again, we're looking for these thick-walled cystic lesions, similar to on ultrasound. What you expect to see on MRI is that they are T1 hyperintense. So this is a T1 weighted image down here, and we can see there are 3 endometriomas on this axial image in this patient. This is the corresponding T2. So they're T1 hyperintense. They tend to be T2 hypointense. So we can see that these two are particularly T2 hypointense. And this one has one of the characteristics of it's kind of a gradient, which can be seen in T2 shading. T2 shading essentially means that if you have a T1 hyperintense lesion, it has T2 hyperintensity, T2 hypointensity. And this is showing sort of the differential of what you can have. You can have a gradual sort of low level T2 hypointensity versus this is also considered T2 shading where you have a very hypointense T2 lesion. Another example of what you can see is the T2 dark spot, which is seen here. So this is another axial T2 weighted image. We can see this is a mildly T2 hypointense lesion, and it has this particular T2 dark spot. This is considered pretty specific for endometrioma, and it's thought to represent chronic hemorrhage, sort of performing a little clot, and there can be calcifications there. And then as mentioned previously, another atypical presentation of endometriosis or endometriomas is this decidualized endometriosis in an endometrioma. So this occurs exclusively in pregnant patients. It has to do with the level of progesterone that's being produced. So we can see in this patient, they have a septated endometrioma, which is this entire thing. It's T2 hypointense, T1 hyperintense. And then they have this irregular nodule that demonstrates some T2 hyperintensity, and it's T1 hypointense. This is a scary finding. It can be a scary finding in these patients because this is also what we would expect to see if this patient had a malignancy. There's a nodule that, and they typically do demonstrate enhancement. So it's important that these patients are followed, and this will typically resolve following childbirth, and that's how you kind of know that it's decidualized endometriosis and not malignancy that's developing. Speaking of malignancy, the reason that we follow these patients is because there is a cancer risk associated with endometriomas. The 2 most common types of cancer that it develops into are clear cell and endometrioid. This happens in about 2.5% of patients with endometriosis, and it will typically develop in an endometrioma. And so what you see, this is a T1 pre-contrast, and this is a T1 post-contrast with subtraction. You can see that there is this, again, T1 hyperintense endometrioma, and it has this T1 hypointense solid component here, which when we see on the subtraction image, we'll no longer see the T1 hyperintensity because we've subtracted that out. And now we can see that there is enhancement in this nodule. The good news for these patients is that this typically is associated with a better prognosis. These are diagnosed at a lower grade and an earlier stage, which may in part be due to that we're screening these patients that have endometriomas with either ultrasound or MRI. And something that makes diagnosis of these patients difficult is that patients with endometriomas can have benign CA-125 elevation. So that's not technically a good marker in order for following them. There are a few other conditions that are not directly related to endometriosis, but are often associated with endometriosis. This includes adenomyosis. And so adenomyosis is essentially when the endometrial cells invade into the uterus. And on ultrasound, what we're looking for is typically an enlarged globular uterus. It has these characteristic Venetian blind artifact that you can see sort of these rays of hypoechogenicity here. And then you look for internal cystic spaces as well. This is associated more commonly with deep infiltrating endometriosis, which is why it's a feature that we want to keep our eye out for. Additionally, patients can have hydro or hematosalpinges. And so this is when the fallopian tube gets dilated, and then you can see it on ultrasound. This makes sense when we're thinking about endometriosis. We're thinking about the adhesions and the fibrosis that is caused. So here we have an example of this tubular dilated structure that you can see here. It's in close association with the right ovary. This is another example of this tubular dilated structure. This has the characteristic cogwheel folds that kind of project into the lumen but don't extend all the way across. Similarly, we can see these findings on MRI. So when we're talking about endometriosis on MRI, the strict definition is when you have a junctional zone that measures greater than 12 millimeters. So if we're looking at this sagittal T2 weighted image, we can see this is a nice normal anterior junctional zone here. And then posteriorly, the junctional zone is enlarged, and we can see these internal T2 hyperintense cystic spaces. Because this is so focal, this is more typical of what we call an adenomyoma versus adenomyosis, as is shown in these two examples, where we have both anterior and posterior walls are markedly thickened, and they're full of these internal T2 hyperintense cystic spaces. Again, here are examples of hydro and hematosalpinges. So this is a T1 weighted image, and we can see this T1 hyperintense serpiginous tubular structure in the left adnexa compatible with a hematosalpinx. And then this is a T2 weighted image, and we can see this T2 hyperintense tubular structure, which is compatible with a hydrosalpinx. So now we're going to talk about deep infiltrating endometriosis. And the important thing about deep infiltrating endometriosis is it's a histological definition. It means that there's a lesion that extends greater than 5 millimeters or greater into the peritoneal or organ surface. It is more strongly associated with symptoms than endometriomas are. The typical place that we will find it is in the torus uterinus and in the uterosacral ligaments, but it can really be anywhere. It can occur in the vagina about 14.5% of the time. It can affect the GI tract about 9.9% of the time, the GU tract 6.4% of the time. And then it also has some interesting presentations that are much less frequent that we'll talk about at the end. When we're evaluating for deep infiltrating endometriosis on ultrasound or MRI, we have to divide everything into compartments to make it easier to sort of identify where there are lesions and also to help us describe them. And theoretically, the surgeon is going to go in and remove these lesions later, so it makes it more uniform and easier to evaluate for them as well. When we're speaking about ultrasound, we divide the pelvis into two categories, anterior and posterior. And what we're using to divide the pelvis are the endometrium and the vagina. So essentially, it's a line that extends from here down the cervix and along the vagina. The anterior compartment is then composed of the bladder, which we can see here. It's composed of the uterovesical space, which is seen here, and it's composed of the anterior part of the uterus, anterior to the endometrial cavity. The posterior compartment then, again, so if we're splitting it just like this, down the cervix and along the vagina, is composed of the posterior wall of the uterus, the pouch of Douglas or the rectovaginal space, and then you have the bowel. So you'll have the rectum here, and then you'll have which aren't well seen on ultrasound until you have disease, but the uterosacral ligaments, which we'll look at. Deep infiltrating endometriosis on ultrasound is highly variable. You can have anything from linear plaques to nodules, and then looking for adhesions is also important. They typically can be, as I said, linear or round. They can be smooth, they can be irregular. A lot of them are avascular. Some of them have a little bit of vascularity. Occasionally you can see internal cystic spaces. So what's really important is if you have a very skilled technician, they can evaluate, it's almost like simulating the physical exam, where they'll do something called the sliding sign. And they'll put pressure when they're evaluating both the bladder and the uterus to see if the bladder and uterus slide separately or if there's any sort of adhesions. And then they can do the same thing for the uterus and the rectum. And again, that can just kind of indicate if there's any sort of adhesions or they're not sliding separately, then it can indicate that there's some sort of deep infiltrating endometriosis there, even if you can't necessarily see an implant. These are some examples of implants. This is kind of along the posterior wall of the uterus here. We can see this hypoechoic nodule. It's a little bit irregular, but it's predominantly rounded. This is an example of bladder endometriosis here. So we can see this is the bladder right here. This is a little bit of the uterus. We see this irregular deposit along the bladder wall, which does have internal cystic spaces and a little bit of internal vascularity. The GU tract is involved relatively infrequently, but when it is predominantly involving the bladder. Bowel endometriosis, particularly in the pelvis, is something that we look for. And here we can see that there are a couple different presentations that you get. This is what's called the comic tail nodule. So this is a little bit of bowel wall here, and it has this deposit along the bowel wall, which this little comet tail. This is the uterus anteriorly. You can see that it's abutting the uterus. So it's possible that this patient likely has some sort of impaired sliding and that there's a little bit of fibrosis between the rectum and the uterus. Another thing that you can see are these linear plaques that cause these retractions that sort of extend out. Here's the predominant plaque, and then all this retracting fibrosis that extends out along there. This is the bowel wall that continues along here. And then this is called the Indian headdress sign. So this is a large plaque, which is along the anterior bowel. So if we look here, this is the normal bowel signature here. You can see a little bit of the mucosa there. This is the posterior wall. So this plaque is along the anterior wall with these spiculated extensions into the bowel wall itself, creating what they call the Indian headdress sign. Bowel tends to be involved in about 5 to 12% of women with endometriosis, and predominantly it involves the rectum or rectosigmoid junction. When we come to MRI, instead of dividing it into 2 compartments, we divide it into 3. The anterior compartment is composed of the prevesicular space to the anterior cul-de-sac, and the organs within the anterior compartment consist of the bladder, urethra, and the ureters. The middle compartment is composed of all the typical organs that we think of for the female pelvis, the ovaries, fallopian tubes, uterus, and it also includes the vagina, the broad ligaments, and the round ligaments. The posterior compartment then extends from the posterior cul-de-sac and then includes the rectum and the uterosacral ligaments and the fat around there. So when we're looking at MRI, we're dividing it into compartments. This is the prevesicular space here. This is the bladder, and this is the anterior cul-de-sac. So all this is contained within the anterior space. Here also is the further extension of this is the uterovaginal septum there. Then we're looking at the posterior compartment. We have the rectouterine and rectovaginal septum. Here's the rectum, and then here is the uterus. Then again, just dividing it, we can see that this is all maintained in the anterior space, prevesicular space, uterus, urethra. Here's the vesicouterine fold or vesicouterine space. This is the middle compartment containing the vagina and the uterus, which is what we can see here. This is an example of the torus uterinis, which is the location of sort of where the corpus of the uterus meets the cervix. That's a primary point where we see a lot of endometrial plaques, so it's a good thing to keep an eye on when you're looking at an MRI. And then in the posterior compartment here, we see the rectum, we see the rectovaginal space here, we see the retrocervical space here. We look at these same features in axial images. Again, we'll see the prevesicular space here, the bladder. You'll see posterior in between the bladder and the cervix. So that's kind of the boundary of your anterior space. Then you'll have in this image, all we're seeing is the cervix to make up the middle compartment. Then the posterior compartment, you'll see your uterosacral ligaments, and you see your rectum, and you have your retrocervical space here. If we come a little bit higher up, again, prevestibular space, bladder, and anterior cul-de-sac. Middle compartment, we have the uterus. Now we can see the fallopian tubes and ovaries, and we can also see these are the round ligaments that are coming off here. And then in the posterior compartment, we have the posterior cul-de-sac and the rectum. So what do we look for on MRI? As we talked about, the definition of endometriosis is you have these glandular deposits that occur outside of the uterus. What can happen over time is that they can become acellular, chronic, and they stop producing, they stop bleeding. And so these are called the acellular deposits, which are just primarily composed of fibrotic tissue and smooth muscle. These tend to be T1 intermediate and T2 hypointense. So we don't see that characteristic T1 hyperintensity that we expect. It just looks more like fibrosis. Versus when we have the active glandular tissue, these are called the cellular deposits, where we see, again, they're T2 hypointense, but we have these foci of T1 hyperintensity and these cystic T2 hyperintense foci as well. The cellular deposits can also be a little bit confusing because they can be associated with restricted diffusion, and that's thought to be attributed to the blood products within them. And you can also see enhancement, and that really depends on the degree of inflammation that the cellular deposits are causing at the time. So just two T2 weighted examples. Along the posterior uterine wall, we can see this is T2 hypointense. It's got these spiculated areas of fibrosis, but we don't see any real T2 hyperintensity in it. So this is compatible with an acellular plaque versus this large plaque here, we can see has all these small T2 hyperintense cystic foci compatible with a glandular deposit, which is along the bladder. So what do we expect when we look at the anterior compartment in terms of symptoms? Patients that have anterior compartment endometriosis typically have involvement of the bladder, as we discussed, or also of the anterior cul-de-sac. These patients that have lesions in the anterior compartment often have additional sites of disease, whether that be endometriomas or different areas of deep infiltrating endometriosis. What we can expect to see, especially if it's involving the anterior cul-de-sac, is that cul-de-sac is no longer visualized. You don't see that well-maintained fat, and you can see that this uterus has a dramatic anteversion. There's a sort of flexion that seems like it's being pulled down by this plaque because, as we know, it's creating fibrosis. This can be described as a cellular deposit because we can see that there is T2 hyperintensity in it, which also demonstrates intrinsic T1 hyperintensity. The patients that have bladder plaques such as this would experience symptoms like suprapubic pressure. If it invades through the mucosa, you can also get hematuria. And if it involves the ureters, you can get issues of obstruction. Similarly, if it involves the urethra, although that's pretty rare. Here's another example of a bladder deposit. Again, we can see that there's tiny little bits of T2 hyperintensity within this lesion, which demonstrate intrinsic T1 hyperintensity. So a cellular bladder deposit. This is just gel within the vagina, which is why it looks expanded. And here is a patient that would experience signs of obstruction. So we can see here this dilated T2 hyperintense structure that looks tubular. On the sagittal, we can track it down. So we know that this is the right ureter. When we follow the path of the right ureter, we see that there is this T2 hypointense irregular lesion. Again, we can see it here. We can see that it's spiculated. It's creating fibrosis. It seems to be pulling the fat in, and it's causing dilatation and right hydroureter. So this is an example of a ureteral plaque with resulting hydroureter. Moving on to the middle compartment, the things that we look for on MRI to be involved in the middle compartment include involvement of the broad and round ligaments and involvement of the vagina. Again, endometriomas we already discussed, so we don't need to cover those. So this is a nice normal picture of what the broad ligaments should look like. They tend to be thin, although it's not technically normal because this patient has a lot of ascites, which is why we can see the ligaments, but the broad ligaments are normal and they tend to be thin and relatively uniform. Versus this patient with endometriosis, we can see there's this nodular T2 hypointense thickening along both of the broad ligaments, and they tend to enhance as well, particularly if they have cellular deposits in them. Another thing you can look for is involvement of the vagina. So again, this is a patient with vaginal gel, which is why the vagina appears a little bit distended and has this T2 hyperintense material within it. And along the posterior wall, we can see that there is this T2 hypointense lesion with all these internal T2 hyperintense cystic lesions, which end up being T1 hyperintense. So we know that this is a endometrial deposit in the vagina. The common symptom associated with this would be dyspareunia or pain with sex. Posterior compartment is where we spend most of our time when we're looking at it on MRI. This is commonly the most popularly involved location and is where we look for our key features. So the first thing we want to look at is the torus uterine, like I mentioned. So here is a nice example. So we can see that this is the uterus, the body of the endometrial canal right there. And this uterus is slightly retroflexed. And what we're looking at is this large plaque here that's involving the torus uterine, which is kind of this area right between the corpus of the uterus and the cervix. And it also kind of extends posteriorly to the rectum here. And it's very irregular and it's got intrinsic T2 hyperintensity, which we see corresponds with T1 hyperintensity. So most of these lesions are seen in this retrocervical area, and they also extend to involve the uterosacral ligaments, which we'll see on the next slide. And the other thing we're looking for, again, is this forced retroversion of the uterus, which is secondary to it being pulled because of the fibrosis that's creating. You can also start to look for abnormal rectal angulation. You know, the rectum should progress pretty smoothly up, and if you see that it's kind of pulled in, you can expect that that might also be due to endometriosis. Other signs, like in the anterior compartment, you can see just obliteration of the posterior cul-de-sac. And then you can also look for rectal specific lesions that don't technically have to extend to the uterus, but can be just based on the rectum. This right here is a T2 weighted image of a retrocervical lesion. You can see the rectum here is separate. There's a little bit of a fat plane that's preserved, but again, we see that there's a cellular deposit here. And this is another example of a retrocervical lesion, and this one abuts the rectum. And again, we can see that it's cellular, it's active. So here, this is a nice example of normal uterosacral ligaments. They're very thin. You can expect to see them on most patients. And then when you have endometriosis, you can see that there's a nodular deposit on this one, and it looks very distorted. You know, the cervix is being slightly pulled in. The rectum appears like it's being pulled in that direction. And this one appears fairly regular. So you can really notice that there's an asymmetry there. And similarly, this is another example. So this is the posterior wall of the vagina, which has again been instilled with vaginal gel. And this one extends from the vagina to the rectum and also along the uterosacral ligament. And we can see that all of these structures are kind of being pulled in and tethered into that area. This is another example. Here we see the cervix and here's the rectum. We see that there's this large plaque in the posterior cul-de-sac. It's involving the rectal wall here, and it's also involving the posterior wall of the cervix with all these extra spiculations. This is a nice example of what we call a mushroom cap. So this is a lesion that's implanted along the rectal wall. And you can see that there's a little bit of T2 hyperintensity along the surface, which is the preserved submucosal mucosal layer. And then what it's called a mushroom cap because it kind of looks like it's pulling the rectum in, which is just the result of that tethering because of that fibrotic deposit. Here again, another thing that we commonly look for, even if you don't see a very clear deposit, occasionally what you can see is this area of tethering between the rectum and the uterus. So you want to look for any abnormal thickened bands that sort of extend between the two of them, even if you don't necessarily see a deposit. And what you can get is sort of this teardrop shape of the rectum, secondary to this deposit being pulled in. And this is just another example of a rectocervical and rectal lesion. Again, T2 hypointense with areas of T2 hyperintensity compatible with a cellular deposit. When we're performing these MRIs, we want to really make sure that we look at each site, particularly when we're talking about obliteration of certain spaces. It's important to have a formula in order to realize what you don't see is actually pathology. So the third thing we look at is really the uterus, and you want to evaluate the version of the uterus. As we talked about, lesions in the anterior compartment can really cause forced anteversion, and lesions in the posterior compartment can cause forced retroversion. Other things you want to look for associated findings like we talked about, as such as adenomyosis, because that also causes a lot of symptoms in women, including heavy menstrual periods. So you want to evaluate for that as well. Next, we look at the adnexa. You want to look at the location. Like we saw on ultrasound, you can have kissing ovaries where the ovaries are retracted and pulled behind the uterus or just in any abnormal space. You want to look for the presence of endometriomas, and you want to look for any sort of hydro or hermatosalpinx that might be related. Then finally, I usually go compartment by compartment, looking anterior, middle, and posterior to evaluate for any sort of endometrial implants. You want to look at whether they're chronic or active, meaning cellular or acellular. You want to evaluate the size. And again, you want to look for any obliteration or tethering, even if you don't see a clear implant. If you see a loss of space or you see any sort of organs that appear abnormally tethered together, that can be an indication that there's something there that you're just not seeing. Then obviously describing the involved organs. Just touching briefly on treatment, a lot of these patients can be treated with hormonal agents since it's hormonally regulated, and then typically NSAIDs or any sort of pain medication, particularly when it gets bad. Laparoscopy, as I said before, is the gold standard for not only diagnosis, but it's also used for treatment because they can do surgical removal of these lesions. The issue is that, as we talked about in the beginning, no one is really sure how it occurs. And particularly if we're thinking that there's some sort of induction or metaplasia element, it's possible that this can recur, and it does tend to recur in about 15% of women, even after they'd had a hysterectomy and bilateral salpingo oophorectomy. For us in radiology, we tend to follow endometriomas annually, just to make sure that there's no sort of solid components that are developing, which would raise concern for malignancy. And then typically, if these patients go to surgery, we will not follow them anymore unless they have new or developing symptoms. What to expect at surgery? So it's interesting that the sort of amount of pigment depends on the age of the lesions. Maybe some of them that have chronically bled might be black, or some of them that are newly bleeding might be more tan. It's hard to know. But these two are examples of this is why an endometrioma is called a chocolate cyst. So you can see that as they cut open this lesion, there's all this thick coagulative brown colored substance that's coming out that's thought to represent the chronic hemorrhage. This is an example of superficial endometriosis. So these are the lesions that we would not see on either ultrasound or MRI, but can be seen in laparoscopy, these small little deposits. The surgeons developed a staging system for evaluation of DIE, and it's similar to what we do in MRI. They look at the implants, evaluating them for location, how big they are, and then how far they penetrate into the organs. They also look at the degree of cul-de-sac obliteration, which is something they can do manually. As they're in the peritoneal cavity in the pelvis, they can try and move the organs to see how much leeway they have, and that's usually graded on a scale of partial to complete. And then they can look for other adhesions within the pelvis, and that they usually grade from flimsy to dense. Based on all this, it's sort of staged on a range of minimal to severe. However, the interesting thing is that this is not felt to correlate with patient symptoms. They had patients that had extremely severe disease with very minimal symptoms. So it's unclear what kind of value the staging system provides, but it's at least a way of knowing what to expect if they need to do another procedure in the future. So now we're just going to come back to radiology and talk briefly about some unusual presentations that we can see. So when we're talking about extrapelvic endometriosis, this occurs in less than 10% of cases that are known, and the frequent sites are the gastrointestinal tract, the GU tract further up, and the thoracic cavity. So that doesn't include everything, because our first patient that came in, this was a 36-year-old patient who was coming in with recurrent abdominal pain and a palpable lump in the right lower quadrant. She had a history of a cesarean section 2 years prior. So she came originally for ultrasound, and we can see we're looking at just the superficial right lower quadrant, and she has this abnormal hypoechoic lesion. It's got shadowing, it's got internal areas of hyperechogenicity, it's got a little bit of vascularity. It's pretty indeterminate based on ultrasound, and so she was recommended to go for an MRI. So on T2, we can see that she has this lesion right here in the right lower quadrant with all these T2 hyperintense cystic spaces. On T1, I don't know how well this is projecting, but we can see that there is a little bit of T1 hyperintensity right here. And on T1 post-contrast, there is minimal enhancement, which goes along with the fact that it was minimally vascular on ultrasound. So she was diagnosed with abdominal wall endometriosis. This was excised, and her symptoms have resolved based on that, but now she will probably need further evaluation to work out whether she has any other signs of endometriosis. And so this is a cesarean section scar endometriosis is something that we do see not infrequently. This is another example of something that you can get in the anterior abdominal wall. This is called a Villar nodule. So this occurs, it's an umbilical nodule, and it tends to be visible on physical exam. It can be brown, blue, or black, kind of like the plaques that we saw, the superficial plaques that we saw at laparoscopy. The symptoms associated with this include swelling and pain at the site, as well as potential bleeding. And so what we see, again, you see this irregular hypoechoic nodule, but it has these internal kind of hyperechogenicity, and it has T1 hyperintensity, and that's how we know it's endometrial tissue. There is an increased risk of intestinal disease associated with these Villar nodules. And so bowel endometriosis is another thing that we can see. Typically, this involves a terminal ileum, although we see an abnormal case here where it's involving the jejunum. The issue with bowel endometriosis, it's pretty nondescript. Unlike everywhere else where we see those typical cellular appearance, these ones tend to be sort of T2 intermediate, T1 intermediate, and then demonstrate pretty avid enhancement. So most of these patients tend to go to surgery to get them resected, and then it's diagnosed as endometriosis, unless they had typical symptoms and they also had known pelvic endometriosis. Because the problem is most of these patients will come in for this exam without a diagnosis of endometriosis, and so it's just kind of gone to resection. These patients can present with melena, particularly if it involves the mucosa. They can present with intussusception, as this can act as a lead point. Less common, they would have perforation or obstruction. Our second patient is a 20-year-old female who keeps coming to the emergency room with a recurrent pneumothorax. So we can see here that she had some imaging done. She has a right pneumothorax. We can see the pleural line right there on chest radiograph. She ended up going for a CT. Again, we can see the pneumothorax, and we see something right here in the pleural cavity. This patient ended up also going for an MRI, and down along the diaphragm, we can see that she has this T1 hyperintense plaque. She then also went for a VATS, and the plaque was excised, and it was found out to be endometriosis. So when these patients have a pneumothorax, we call that a catamenial pneumothorax. Other presentations that can happen include hemothorax or hemoptysis, particularly depending on where the lesion is. If the lesion is not pleural, if the lesion is within the lung, hemoptysis might occur. That would also be how lung nodules would present. Over 50% of these patients are thought to also have or do also have pelvic disease. So it's not a common primary diagnosis. Lastly, this is just an example of nerve endometriosis. So we can see here that there's this abnormal plaque in the pelvis, and it's kind of extending outside of the pelvis along the sciatic nerve along the right sciatic nerve. Again, we can see here it is again, it's abnormal, it's T2 hypointense, and it's avidly enhancing, and it extends along the course of the right sciatic nerve. So this patient just presented with sciatic symptoms and then was found to have an endometrial plaque there, and then further evaluation demonstrated additional deep infiltrating endometriosis. All right, and that's all I have. And again, this is the link, and this is the QR code for anyone that needs it, and I'm happy to take any questions.
Dr. Vandeventer, first of all, I want to thank you for an excellent presentation. There was always some bits and pieces we learned, even as the body imager. I've learned something from the presentation. That's how I love these presentations. So with that said, I would like to ask a few questions that have come through the Q&A. Let me kind of organize the concept. One, I think, kind of deals with protocoling. So the question is, do you recommend intravaginal gel? And if I could piggyback my question on that, and that is, we have various protocols for the MR pelvis. Is there any specific things you would add in the protocol with that? So could you please address that?
Yeah, so I actually personally, I've read it as both. Where I trained when I did my body MRI fellowship, half of our attendings preferred it with vaginal contrast and half of them didn't. It depends on what sort of symptoms they have. If they're having vaginal symptoms and you're worried about a vaginal plaque, I think vaginal gel is helpful. If they don't, sometimes it can cause too much distension and obliterate sort of the rectovaginal symptom artificially, and then you can miss plaques there. So I think it's very patient depending. I think in general, I don't use vaginal gel, but there can be conditions where it's helpful. And then in terms of
Yeah.
important sequences, so your T2s, I like very specific T2s of axial, coronal, and sagittal plane. And then we usually typically do an in and out as well. And then that looks for, especially for when you're looking for endometriomas and you want to make sure that it's not a dermoid. I mean, tends to be obvious, but if there's any sort of T1 hyperintensity that you're not sure whether it's fat, an in and out can be very helpful, typical also with the fat sat. And then a pre-T1 and then a post-T1, both of those should be fat saturated. And then also a subtraction is crucial, especially in these cases.
Thank you very much for that. The next set of question kind of deals with differentiating the endometriosis from other entities. So I think you alluded to some of that with the enhancement pattern, but maybe you could talk about how you differentiate the appearance of endometriosis from other malignancies in the pelvis.
Yeah, so again, it can be tricky. So one of the things you want to look for is whether there's any sort of nodular component. So a lot of the endometrial plaques have a very specific appearance on T2. They're very T2 hypointense, and they occasionally have those T2 hyperintensity. Malignancy in the pelvis tends to be what we call the evil gray color. So you're really looking for that T2 intermediate signal. And I think that's why decidualized endometriomas causes a lot of issues, because it has that intermediate T2 signal, which is very suspicious, and why they're very closely followed throughout childbirth, and then also after the child is delivered. So I think looking at the T2 signal is very important. Diffusion, again, can be tricky, but it's something that you want to look at. Like I mentioned, occasionally the cellular deposits can have some sort of restricted diffusion, but that tends to be more associated with the areas that are active, not sort of the entire lesion. And then it also isn't typically as hypointense on ADC than as a malignant lesion would be. Other features, a pattern of enhancement, again, can be important, again, but it is tricky. That's why a lot of these patients just continue to be followed. And you're looking for a general sort of overall feature. If they have a bunch of endometriosis, then it's more likely to be endometriosis, versus if you see one lesion that you're more suspicious about, that is what I would say. Yeah.
Thank you very much on that. And then I think the third question, I have one question as well, but I don't see any more questions. In one of the other groups, they talked about how frequently do you come across the catamenial syndrome, which I think was in the slide, right? I think you mentioned that already. The one other question I had is, the deep infiltrative endometriosis, is that, so there's a lot of hormonal treatments you mentioned, right? But then the deep infiltrative endometriosis is then managed differently with surgical approaches at that time?
Yeah, the hormones tend to not be as helpful for deep infiltrating endometriosis. And that's really where laparoscopy, I think, comes in. The problem is, like I mentioned, a lot of these patients have recurrent symptoms even after surgery. And some of that is due to recurrent plaques. We see patients that had a surgery a while ago and then come back with many new cellular plaques, regardless of, they typically will do a laparoscopy and then insert them on hormonal therapy, or some combination of both. They can insert them on hormonal therapy first. But we often see a lot of recurrence. But occasionally we see patients also that, used to be screened, had laparoscopy, their symptoms went away, come back later for like a MRE or something, and they have a whole bunch of new endometriosis, but they have no pain. So it really is a very fascinating disease process in that the amount of lesions that you see has almost no bearing on the symptoms that the patients present with.
Thank you very much. I don't have any more questions in the system. Abhinav, did you have anything else to add?
We do have one question.
For the QR code. Go ahead, Abhinav. Sorry.
We do have one more question that just came in. They're asking if rectal gel is something recommended for the protocol.
We don't use rectal gel. You can use rectal gel if you want. Again, I think it's kind of the type of symptoms that the patients present with. Typically in these patients, they have a lot of pain and issues already. So we tend to steer away from rectal gel from that reason. And a lot of the deposits, you don't need the rectum to be expanded to see. It's unusual they would be every sort of deposit, because of the way endometriosis progresses, it attaches to the outer wall and then grows inward. So it's not difficult to it's less difficult to identify those lesions. So you don't really need the rectum expanded.
That's good to know. And a new question just came in. They're asking if there's an optimal time to scan the patients during the menstrual cycle.
That's a great question. There's not one that I've known of. I think most of the symptoms tend to be at their maximum about 48 to 24 hours before menstruation begins. But they tend to be, if they're active deposits, they're active regardless of the menstrual phase. So it does not really matter. But I don't know that anyone's ever actually looked at that. It's a good question.
I think we don't have any more questions. So I think that's about it. I just wanted to make one announcement that today's lecture qualifies for an AMA Category 1 credit, courtesy of Brown University. So US-based physicians will be able to claim that, and Dr. Vandeventer has been very gracious to put the barcode and the link on the screen. So please feel free to claim the credit. And I think that's about it. That concludes our grand rounds for this week. Thank you.
Thank you, Dr. Vandeventer, and thank you, Abhinav. Okay, have a good day, everybody. Thank you.